Hello Dentospedia learners. In today's case study, we'll discuss another important high-yield topic for all dental board exams. We'll move step by step: history, findings, investigations, questions, and exam tips. Here is your clinical scenario for this case study. Refer to this information for questions 1 to 5. Mr. Ali, a 52-year-old male, attends the dental clinic complaining of difficulty chewing on his right side. He has a history of controlled hypertension, but does not smoke. On examination, his oral hygiene is fair, with localized plaque deposits. The gingiva, around the mandibular right first molar, is inflamed with bleeding on probing. Periodontal probing reveals 7 mm pockets on the buccal and lingual surfaces, and there is grade 2 furcation involvement, detected with a Nabers probe. Tooth mobility is grade 1. A periapical radiograph shows horizontal bone loss extending into the furcation of tooth 46, with no periapical pathology. Other teeth show mild generalized chronic periodontitis. Let's have a quick breakdown of the patient's profile: age, gender, chief complaint, and medical history. In this case, we see gingival inflammation around the mandibular right first molar with bleeding on probing. Periodontal charting shows 7 mm pockets on both buccal and lingual surfaces. A Nabers probe confirms grade 2 furcation involvement, and there is grade 1 tooth mobility. The radiograph reveals horizontal bone loss extending into the furcation of tooth 46. Now that we've reviewed the case history, findings, and investigations, let's test ourselves with some interactive questions. I'll show you the question with 4 options, give you a few seconds to think, and then we'll reveal the correct answer with explanation. Question 1. According to the 2017 AAP and EFP classification, what stage of periodontitis best describes tooth 46? Option A. Stage 2 periodontitis, CAL, 3 to 4 mm, pockets up to 5 mm, no furcation involvement. Option B. Stage 3 periodontitis, CAL 5 mm or more, pockets 6 mm or greater, with furcation involvement. Option C. Stage 4 periodontitis, CAL 5 mm or more, with occlusal trauma and masticatory dysfunction. Option D. Generalized stage 3 periodontitis, multiple teeth with CAL 5 mm or more. Take a few seconds to think. The correct answer is B. Stage 3 periodontitis. Why? In this case, tooth 46 shows 7 mm pockets and grade 2 furcation involvement. That fits stage 3. Stage 4 would require more severe functional problems, such as bite collapse or drifting. Now for the distractors. Stage 2 is limited to shallower pockets and no furcation. Stage 4 is too severe for this case. Generalized stage 3 would require multiple teeth with the same advanced loss, but here it's localized mainly to the mandibular first molar. Question 2. Which factor most strongly determines the prognosis of a molar with grade 2 furcation involvement? Options are: A. The patient's age. B. The depth and configuration of the furcation defect. C. The number of furcation entrances present. D. The use of systemic antibiotics in therapy. Take a moment to think. The correct answer is B. The depth and configuration of the furcation defect. Why? Prognosis in furcation involvement is mainly influenced by the anatomy, the horizontal depth, vertical component, root divergence, and how accessible the defect is for cleaning. These factors determine whether long-term stability is possible. Now the other options. Age is not a direct determinant. The number of entrances can complicate access but is not the primary factor. Antibiotics have limited benefit unless combined with mechanical therapy, and do not decide prognosis. Question 3. Which surgical option has the highest evidence for managing a grade 2 mandibular molar furcation defect if initial therapy fails? Option A. Apically repositioned flap. Option B. Guided tissue regeneration with barrier membrane, plus or minus bone graft. Option C. Gingivectomy. Option D. Repeated root planing every 3 months. Pause for a few seconds and think. The correct answer is B. guided tissue regeneration with barrier membrane, sometimes combined with bone grafting. Why? Regenerative approaches have the best outcomes in grade 2 furcation defects, especially in mandibular molars, where the anatomy is favorable. These techniques can restore lost attachment and improve tooth prognosis. Now let's look at the other options. An apically repositioned flap is useful for crown lengthening, not regeneration. Gingivectomy only removes soft tissue and does not address bone loss. Simply repeating root planing will not resolve a furcation defect once it is established. Question 4. Which clinical measurement best predicts the risk of future attachment loss in this patient's mandibular molar? Options are A. Probing pocket depth 7 mm or more at baseline. B. Bleeding on probing in the furcation area. C. Tooth mobility grade 1. D. Plaque index score. Pause for a moment and think. The correct answer is B. Bleeding on probing in the furcation area. Why? While deep pockets indicate severity, it is bleeding on probing that is the strongest predictor of future periodontal breakdown. Persistent bleeding reflects ongoing inflammation and active disease. Now the other options, a deep pocket shows current severity, but not necessarily activity. Tooth mobility grade 1 is mild and not a reliable predictor of progression. Plaque scores are useful for monitoring hygiene, but are not the single best predictor of attachment loss. Question 5. During maintenance therapy, which professional recall interval is most appropriate for a patient with furcation involvement and a history of stage 3 periodontitis? Options are A. Once every 12 months. B. Every 9 months. C. Every 3 to 4 months. D. Only when symptoms arise. Take a few seconds to think. The correct answer is C. Every 3 to 4 months. Why? Patients with furcation involvement and advanced periodontitis are considered high risk. They require supportive periodontal therapy at short recall intervals to prevent recurrence of disease and tooth loss. Now the other options, annual or 9-month recalls, are too infrequent for high-risk perio patients. Waiting for symptoms is unacceptable because periodontal disease is usually painless until advanced. Management starts with oral hygiene instruction and thorough scaling and root planing. After 6 to 8 weeks, the patient is re-evaluated. If deep pockets remain, surgical options such as flap surgery with guided tissue regeneration are considered for the grade 2 furcation. Long-term supportive therapy every 3 to 4 months is essential to maintain stability. For this patient, the prognosis is guarded to good if treatment is carried out and supportive therapy is maintained. However, without regular maintenance, the outlook becomes poor, as furcation defects usually progress and may eventually lead to tooth loss. Key pearls to remember. Always use a Nabers probe to assess furcations. Stage 3 periodontitis means deep pockets with furcation involvement, while stage 4 adds functional issues. Grade 2 furcations respond best to regenerative therapy when anatomy allows, and most importantly, long-term success depends on supportive periodontal therapy every 3 to 4 months. Follow us on social media. Download our app Dentospedia on Play Store and App Store.